So we're going to start speaking about the use of narcotics for sedation, analgesia, or treatment of neonatal abstinence syndrome. So we have, again, tremendous debates within neonatology, whether it be for preterm infants and term infants. Mark Turner and I, with Robin Steinhorn's encouragement, just wrote an editorial for the Journal of Pediatrics on the use of propofol for routine sedation prior to intubation. And many of our adult colleagues tell us that we're not very nice people as neonatologists, because all the adults and older kids, when they're on ventilators, they're heavily sedated for weeks or even months at a time, because it's not a pleasant process, and yet we don't do that. We don't do that in many cases because we're worried about the side effects of the drugs and the potential implications of that long a treatment on a developing brain. And all of the same sorts of things that we've discussed, both short and long-term endpoints, have been important. So there's a initiative internationally called Smart Tots, and that originated through the FDA with other regulatory agencies, with the International Anesthesia Research Foundation, because there was increasing amounts of preclinical animal data that newborns treated with routine anesthetics, including inhaled agents or narcotics, there was a 12-fold increased risk of brain cell death after that, and that could be short periods of time, up to 4 hours, and a concern that every time you anesthetized a baby for surgery, that you were knocking off about 5 IQ points. And certainly for babies that had multiple surgeries, it was much more complicated. So as we looked at some of those initiatives and concerns about different use of anesthetics, and many of those studies are ongoing to evaluate that better, both short and long term, part of the concern that people said to us is, well, don't you anesthetize these babies with narcotics and keep them heavily sedated in the NICUs, sometimes surgical, or babies with severe lung disease or others, for weeks at a time? And what are the implications for those narcotics? We're also treating babies with narcotics who are withdrawing from drugs, as opposed now called a neonatal abstinence syndrome, or NAS, or NOWS, right, Jerry? NOWS. Neonatal opiate withdrawal syndrome is the new catchword. And so if you haven't been aware of it, there's been a tremendous epidemic of this. There's been anywhere from a 4 to 7-fold increase in the number of these babies in the U.S. We've seen large increases in Canada, in the province of Ontario specifically. There's been certainly a large number of these babies in the UK and Australia as well. So we thought it would be appropriate to talk about the use of narcotics and treatment of those babies. Sometimes we give it to them for months at a time. These babies have been exposed to multiple different drugs. At some point, it became acceptable to allow a mother to be on 6 or 7 different medications while pregnant, psychotropic medications, because since there's no evidence of harm, it must be safe. And that seems to be the current climate and thinking in clinical medicine, which we all in this room recognize is really critically flawed thinking. So as you heard from Bob earlier, we have this tremendous amount of talent in the ClinPharm Working Group. They did an enormous job getting this document together and deserve a tremendous amount of credit. And now they're just anxious to get started on something new. And so this is certainly one of the projects that we're going to be presenting to you as a group to get your feedback and input to see if this is something you want to hear more about. So without further ado, I think we'll start on 2 of our talks. The first speaker is Stephen Patrick, and for those of us that have been in the field for a long time, Stephen represents really one of the best parts of watching young faculty members thrive and grow, and at a very early stage in their career have a significant and dramatic impact on the field. And it reinforces my optimistic approach to research and where this field is going to go in the future. So Stephen is at Vanderbilt University, did his training at the University of Michigan. He is one of the leaders in understanding the epidemiology of neonatal abstinence syndrome, where we've been, how we got here, and why the numbers seem to be increasing so dramatically and so quickly in the U.S. and in other parts of the world. And he's going to talk a little bit about the epidemiology of NAS, and then we're going to have Jack Aranda, who is going to speak about narcotic use for sedation in the NICU, and then we can talk about projects from there. So Stephen, welcome to London, and we're delighted you could be here.
Well, thanks for such a gracious introduction. Let's see. Well, I was tasked with beginning the introduction to neonatal abstinence syndrome and understanding it in the context of where we are in the prescription opioid epidemic. And in part, I think that begins with talking about where we've been, at least in the recent history, when we think about how we deal with pain in our hospitals and in our outpatient clinics, and kind of how we got here. That's a bit of a different version. Well, there's an error on the slide, so you're going to have to trust me on what this says. I'd like to begin with this slide, which actually is a paragraph from the New England Journal of Medicine from 1988 that has nothing to do with leukemia. There's an error on the slide sometimes for some reason that occurred. But what it says is addiction rare in patients treated, patients with pain treated with opioids. And what this was a case series that basically discussed that if someone had pain and you treated them with opioids, addiction was rare. And again, this slide is a bit off, but again, what you're going to have to trust me that it said was that we conclude that when you treat someone with opioids that's in pain, addiction is rare. And from this, we got the figure of 1%, that about 1% of people that were treated for pain ultimately ended up developing addiction. And today we know that's not true. But this was some of the literature that we had at the time that began where we've been over the last 30 years or so. And our Surgeon General, the U.S. Surgeon General, has recently begun a campaign about opioid use. And one of the things he says is that this began, the path that we're on was paved with good intentions. And I think that's certainly true. If we fast forward a bit, in the mid-1990s, the American Pain Society developed pain as the fifth vital sign, and we began to be more aware of pain, certainly in all of our hospitals, and it became to be a metric that we assess on every patient. Certainly today I go get my eyes checked, and someone asks me if I'm in pain. And so it's become part of what we do and how we are in healthcare. And again, this was in part because we had disparities in how we were treating pain. We had issues with untreated pain, again, talking about the good intentions that we've had. Soon thereafter, the Federation of State Medical Boards published model guidelines for the use of controlled substances and the treatment of pain. And if we fast forward a bit, in 2003, we began to see some issues. The New York Times reported a tripling of those abusing opioids, young adults abusing opioids between 18 and 25. And that same year, the FDA and DEA began to crack down on internet purchases of opioids. Fast forwarding a bit further, in 2007, the maker of OxyContin, Purdue Pharma, pled guilty to criminal charges that they misled regulators, doctors, and patients about the drug's risk of addiction and its potential to be abused, resulting in a $600 million settlement. And as you can see, all of these things came together, and in part of the history that I think is important that we think about with where we are with opioids in the U.S. and internationally. And what we've seen is a rapid expansion of opioid use, particularly in the U.S. So let's talk a bit about some recent trends in opioid use. This is a graph from the Centers for Disease Control and Prevention. On the y-axis here is rate, and on the x-axis is year. We'll compare a few different things. Well, as you can see, over the last decade, we've seen about a 4-fold increase in the U.S. in number of prescriptions written for opioid pain relievers, and a similar increase in treatment facility admissions and overdose deaths. you can see the similar trend. The lines line up pretty clearly. You can see the trend throughout that we've experienced in the U.S. This is also from the Centers for Disease Control and Prevention. As you can see, the darker the color, the more intense the rate of opioid prescribing. And if you'll take your attention to the bottom right-hand corner, I think the scale of this, the legend, is striking by itself. If you look at the bottom, you see number of painkiller prescriptions per 100 people, and the scale goes up to 143. So about 1.5 prescriptions written per person in that state. The state that I live in Tennessee, has the second highest rate of opioid pain reliever prescriptions. Again, with about 1.5 prescriptions written for residents in the state, highlighting the problem that we're beginning to experience. If you take it all together, prescriptions again rose about 4-fold over the last decade for opioid pain relievers. They now account for more overdose deaths than cocaine and heroin combined, and more deaths than car accidents. More people die in the United States from opioid pain reliever overdoses than car accidents. And that's really something striking to consider, because in many cases now, people can personally relate to the opioid epidemic. And you can also think about it as a public health response. We've had a public health response to guardrails and other things like that. This is a public safety issue and a public health issue that merits attention. In 2012, there were 259 million prescriptions in the US written for opioid pain relievers, and that's enough for every American adult to have a bottle of pills. And if we put this into some global context, the US accounts for about 4.6% of the world's population, but 80% of the world's consumption of opioid pain relievers. And one of the things that's worth mentioning in the US that we're beginning to experience is an increase in heroin. We've seen about a 3-fold increase in the last 4 years in heroin-related overdose deaths. Today, those who use heroin, about 4 out of 5, began with misuse of opioid pain relievers. So in many cases, this still all goes back to the opioid pain reliever epidemic, but shows the complexity of the problem that we're seeing. As we're becoming more aware of the problem of opioid pain relievers, there's been a supply-side response to that, and we've seen prices on the street for opioid pain relievers go up. At the same time, cartels have been smart, have moved in, and we've seen a decrease in the street value and the street price of heroin in most U.S. cities. This is worldwide consumption of opioids, and again, on the pink line here, these are methadone morphine equivalents. You can just see massive rises in all different types of opioids throughout the world. This is graphically looking at just representing opioid consumption. This is morphine equivalents throughout the world. Again, the darker the blue, the more intense the consumption. And what again is striking about this, there are clear, as we talked about a bit, the complications from opioids in the U.S. So we have overutilization of these medicines, likely in many cases, but certainly parts of the world where pain remains untreated or undertreated. And that certainly is important when we think about solutions and paths forward, not only in the U.S., but worldwide. Okay. So I think that really helps us frame and understand neonatal abstinence syndrome and where we are today. So what is neonatal abstinence syndrome? Well, it's a withdrawal syndrome experienced by drug-exposed infants shortly after birth. And it generally follows opioid exposure, though if you look in the literature, there are other things that have been implicated, including alcohol, benzodiazepines, and barbiturates. And the literature suggests that around 40 to 80% of infants exposed to heroin or methadone experience neonatal abstinence syndrome. Some of our research suggests that those exposed to opioid pain relievers are a little bit less likely to have a withdrawal syndrome, around 5%, depending upon the complexity of different exposures. Well, this is what I think about when I think about an infant having drug withdrawal. This is the infant that we see in the delivery room, right? And at the time of delivery, the infant has been exposed to an opioid, and then the cord's cut, and that exposure is no longer there. And then sometimes we end up with this infant who is pretty displeased with us in the unit. And when we think about what neonatal abstinence syndrome looks like, we can think about where opioid receptors reside. So certainly in the GI tract, we can see common clinical signs, including poor feeding, vomiting, and loose stools, leading to dehydration and poor weight gain. Common CNS signs, including tremors and hypertonia, leading to irritability, decreased sleep, and exaggerated reflexes like the Moro and seizures. When I describe neonatal abstinence syndrome to parents and to policymakers, I usually describe it as a colicky baby times 5. We've all experienced this, and for many of us who have experienced a colicky baby as well, we can relate to that, and certainly many of our nurses can also relate to that in our units. Autonomic activation, including tachypnea, yawning, and dilated pupils. Well, making the diagnosis is complex, and I think it's one of the things that we'll talk about today. I think this is advancing without me a bit. Well, we know that not every opioid-exposed infant develops withdrawal, and for unclear reasons. We can have 2 infants have the exact same exposure. One infant develops withdrawal, and another infant doesn't. And we're doing some work, including some work led by Dr. Davis and his group, and to understand why that occurs. It's helpful for us to know exposure history, either through a verbal history from mom or drug screens from mom or baby, to understand if there's been an exposure so that we can look for clinical signs of drug withdrawal. Well, the diagnosis, though, is made by a scoring system, and the most commonly used scoring system in the world is a modification of the original Finnegan score that was developed in the 70s. I like to put this up here because for me, it's a bit of an overwhelming scale. I feel pretty confident that I can diagnose fever. I'm pretty good at that one. But there are many things here that are very subjective. Things like regurgitation versus projectile vomiting, describing the level of tremors. And certainly there are tools to begin to standardize this. But we know that there is substantial inter-rater reliability issues with these scores. The scoring tools that we have today have not undergone rigorous instrument development and that validation process for many of the things we use in medicine. And in part, this is perhaps one of the reasons why we have such inter-rater reliability. The cut point threshold, again, a common threshold to utilize is 8. What does a 9 mean? What does a 7 mean? What does a 10 mean? That really hasn't been asked in a rigorous way. In the scoring context, and again, these tools were developed 40 years ago. They've never been tested in preterm infants. They were tested initially and developed on pure opioid-exposed infants. Today, polysubstance exposure is really the norm. And it's important to remember that in the original Finnegan paper, length of stay was around 6 days, and certainly in the U.S., as I'll share with you in a bit, our people would be happy with us if our length of stay was 6 days. So how do we treat? Well, the goal of treatment is to control withdrawal and minimizing the complications, including seizure. And certainly that begins with non-pharmacologic interventions. We're learning more and more about that, and groups are really beginning to pioneer some non-pharmacologic interventions. And that includes things like keeping mom and baby together, controlling the environment, promoting breastfeeding when it's appropriate, and those are things we can continue to discuss. But certainly severe withdrawal should be treated with an opioid, either methadone or morphine, and more data to come soon from the work of people up here, Dr. Davis and his group, on which of those might be better. Well, I want to talk a bit about global neonatal abstinence syndrome. So what's happened in the world as we've seen an increase in opioid pain relievers throughout the world. And this is work from our group and from plenty of others internationally. So what we've seen is a rise over time in Ontario, Canada. We've seen a rise and then a decrease in the western part of Australia. In the U.S., we've seen a stark increase. This is some of our work describing about a 5-fold increase in neonatal abstinence syndrome in the United States. And in 2012 in the U.S., one infant was born on average about every 25 minutes having signs of drug withdrawal. And then again, some data on England as well from some collaborators here locally. So again, you can see that this is an international problem, but certainly in line with the amount of opioid consumption we have in the United States, appears to be a bigger problem where we are. And I wanted to highlight just some heterogeneity within the U.S. as well. Sorry. All right. I put on West Virginia, which is West Virginia is my birthplace. West Virginia has seen a substantial increase in neonatal abstinence syndrome. Again, comparing the rates of neonatal abstinence syndrome in nationwide are about 5.6 per thousand births, but in West Virginia are about 30 per thousand births. And that's in line with other opioid-related complications. West Virginia has the highest rate of opioid-related overdose deaths in the U.S. The second highest state has half. So again, showing the burden in some communities. And this again is showing some of the variability from areas of the U.S. to other areas. These are by U.S. geographic division, so states are grouped together. In the area of the country where I live, we have the highest rates of neonatal abstinence syndrome, about 16 per thousand births there, the darker blue. And that's that's first to the upper Northeast, which has a rate of around 13 per thousand births. These are data that we collaborated with the Centers for Disease Control and Prevention, published just a month ago. Again, highlighting the variability, and we were able to get state-to-state data for at least 28 states. And as you can begin to make out, the high-intensity states, again, having rates of more than 30 per thousand births, West Virginia, Maine, and Vermont, and seeing a 30-fold difference, more than 30-fold difference between those states and states like Hawaii, who have a much lower rate of neonatal abstinence syndrome. Well, what does this mean? Again, this is from some of our work. So infants that are pharmacologically treated in the United States for neonatal abstinence syndrome stay a bit more than 3 weeks, 23 days on average in the hospital. Total inflation-adjusted charges grew from around $75,000 to $93,000. These are charges, not costs, so these are the bill that's written for just hospital charges in 2012. If we look at the total, and again, showing the burden of neonatal abstinence syndrome in many of our NICUs. These are data from pediatrics. Again, showing the massive growth of neonatal abstinence syndrome. This is proportion of NICU days for neonatal abstinence syndrome. You see that on the y-axis, and the x-axis is year. What strikes me about this looks like a very similar trend. The outliers are what strike me about this. That we have some NICUs in parts of our country where 50% of their hospital days are attributed to this one problem. And that to me is striking. And we hear that in many of our communities as we're beginning to understand how do we begin to respond to this and even to be able to deal with resource allocation. Looking at the total U.S. hospital bill, for Medicaid, it grew from, Medicaid is a joint program between the federal and state governments. It's jointly financed by the state and federal governments and is administered at the state level. This grew from $560 million to $1.2 billion in 2012. In total, the total U.S. hospital bill grew to $1.5 billion in 2012. To put that into some context, the NICHD's budget's around $1.3 billion. Just showing you the scope of the problem. And that's just for the birth hospitalization. I want to close and talk about research gaps, because really that's what we're here to do, right? And hopefully some of the things that we'll talk about have provided some context for. One of the things that I think is important that we consider is the continuum of care. We oftentimes focus in just at the time of birth, but as we think about how do we approach this problem, it's really helpful to think about the different parts of the life continuum. Where are the appropriate points to begin to intervene and to develop both strategies and new medications? If we focus just on the time of birth, we end up missing a fair amount. The Substance Abuse and Mental Health Administration estimates there are around 440,000 substance-exposed infants born each year, but we detect about 5% at the time of birth. So our approaches to this really need to be looking at the entire continuum, both prenatally, pre-pregnancy, and in childhood and beyond. When we think about gaps, I think it's worthwhile to look at some of the work that's been done, beginning to highlight the gaps that are there that I think is applicable. This is from the Government Accountability Office within the U.S. They released this early last year. It's entitled Prenatal Drug Use and Newborn Health Federal Efforts Need Better Planning and Coordination. But one aspect of this GAO report was talking about research gaps. And they did a bit of qualitative work with researchers as well as policymakers to understand where the gaps are and perhaps what we could do about them. Here are the most common cited gaps, and we'll talk about them in a bit more detail. But treatment of prenatal opioid use, including medication-assisted treatment. We know that the standard of care for women with opioid use disorder is medication-assisted treatment, drugs like methadone and buprenorphine. Those have been associated with superior infant outcomes, things like increased birth weight and more likely to go to term, and a decreased rates of relapse for mothers. Long-term effects of prenatal opioid use. To date, there hasn't been a single long-term study of infants exposed to prescription opioids long-term. Treatment of neonatal abstinence syndrome. Screening and diagnosis of neonatal abstinence syndrome remains a problem. Understanding NAS and severity of NAS. Appropriate research methods or available data. It's been the topic of much of our conversation today. Knowledge of best practices in opioid prescribing. Some of our work has described opioid prescribing in pregnancy. Just an aside, of 110,000 births in the state of Tennessee in a 3-year period, more than 30,000 were prescribed opioid pain relievers in pregnancy, again showing the scope of the problem. Prevention, including prevention of substance use disorders or pregnancy in women with opioid use disorders, screening for prenatal opioid use, and understanding prenatal opioid use. Some of the specifics that were noted were treatment of opioid use disorders in pregnancy. Some of the data on best practices for medication-assisted therapies have not really been well hashed out. Much of that data is old. It's most of it are from heroin. There really needs to be additional studies that are done. Barriers to treatment. There's an exceedingly low amount of people that engage in treatment with opioid use disorder and substance use disorders in general in the U.S. for a multitude of reasons. How do we improve those barriers? They cite the subjectivity of the scores that we utilize to diagnose neonatal abstinence syndrome and the labor intensiveness of the Finnegan NAS tool. Treatment of neonatal abstinence syndrome and effectiveness of different drugs. We really do lack a robust literature on many of the drugs that we have. And long-term outcomes. Again, reaching on the theme that we've discussed a bit, we really do need some long-term outcome data on opioid-exposed infants. I thought it was interesting, too, they talked about some of the barriers to research. And some of the ones they talked about where they discussed were identifying and retaining pregnant women. They noted multiple studies with low numbers and high dropout rates. A reluctance to participate in studies due to possible criminal repercussions was cited by many. Polysubstance use. Polysubstance use is common, even legal substance use. Of infants diagnosed with neonatal abstinence syndrome, smoking is exceedingly common in much of our studies. About 80% of women smoke, and certainly other drugs, including legal drugs, as Dr. Davis pointed out, are common. Variation in the expression of neonatal abstinence syndrome, the need for large numbers in studies to begin to understand the effectiveness of different therapies. Funding and capacity. Do we have the teams and the resources available to begin to ask some of these questions? In closing here, standardization, and so one of the things that we need now, kind of moving forward, I think standardization and structure for international efforts. What is neonatal abstinence syndrome or NALS? We need to, one, I think, begin to think about the terminology we use. I think personally that neonatal opioid withdrawal syndrome is more understandable by many people, but we have some conflict about what that means, and we can certainly, I've had robust debates about that as well. A gold standard definition. What is neonatal abstinence syndrome in one hospital or even in one unit of a hospital may be different elsewhere. So there's really the need for a gold standard definition, an objective means for diagnosis that has been validated, that has been rigorously evaluated. And then relevant outcomes. We were talking a bit about patient-centered outcomes. Much of our outcomes that we utilize today have a lot to do with utilization, things like length of stay. But length of stay is certainly not family-centered. It doesn't take into post-discharge outcomes. And I've really liked kind of some of the things we were talking about. Talking about quality of life, function, all these other things are important when we think about family-centered outcomes. And of course, standardizing outcomes for site international comparisons. So in summary, opioid use and neonatal abstinence syndrome are not new, but there are challenges with the recent surges in incidence. Opioid use and neonatal abstinence syndrome are international problems with particularly high rates in North America, Europe, and Australia. And really a coordinated international agenda will facilitate better research and more effective coordination, ultimately improving outcomes for this vulnerable population. I have lots of people to be thankful for that contributed to much of the work that I discussed, including our funders, the National Institute on Drug Abuse, and there's my email address. Thank you.
Thank you very much for a great presentation. And looking at the time, I think we move quickly to Dr. Jack Aranda, and probably everybody knows him, but a short introduction. I think he's the father of neonatal pharmacology. He started his studies with caffeine, and we still use it ourselves every day, and we try to give it our babies even more because it seems to be very good. But that's not the reason why he's going to present today. He's going to present about what happened in utero. It can be very devastating, but what we're doing in the NICU might also not be that good. So, Jack, please go ahead.
Thank you, Johnny. Thank you for reminding me that I'm the oldest person here in this unit.
I didn't say that at all. The wisest.
Anyway, I am assigned to discuss with you analgesia and sedation in the newborn. And unlike Dr. Patrick, I'm going to just talk about all these wonderful drugs that we are giving to these babies in the NICU, not before they are born. So I will talk about some of these items because we now are, you want me to stick with time, 10 minutes or more? 15? Okay. So use of analgesic and sedation in the NICUs, and outcome of unrelieved pain and treatments, and then the opiates, and then gaps in knowledge probably. So it's basically a consensus that newborns can feel pain. I was quite interested to go back to an old article coming from UK sometime in the 1990s, where 20% of the pediatric anesthesiologists think that babies did not feel pain. And so some of these babies actually went onto laparotomy, thoracostomy, without any anesthesia. But now we are better, and there's the humane and ethical imperative to provide comfort and relieve pain in a vulnerable, nonverbal population. And we know that unrelieved pain in these babies, particularly from the work of Sani Anand, showed us that babies do get metabolic acidosis and goes on to die if they have continuous unrelieved pain. We also know that there's increased pain sensitivity due to immature pain modulatory mechanisms, as well as prolonged hyperalgesia following tissue injury, and that babies can have acute physiologic and behavioral responses to painful stimuli, like they desaturate. And we now know that intermittent hypoxia or repeated desaturation is not very good for the eyes nor for the brain. So there's a constant battle in the NICUs to how to best relieve pain at the same time, how to balance this so that we can protect these babies from the known and unknown acute and long-term adverse effects of these drugs. As I mentioned, as you know on the top, it says there's a very wide variation that occur in NICUs and countries. Now, it was very difficult until recently to find out what the practices are. We have some old data from Canada and from old data from Italy, but lucky enough, there is the European study that looked at this that just got published a few months ago, and they had studied from October 2012 to June 2013, 234 NICUs in 18 countries. It's a prospective cohort, and 6,680 babies were enrolled. This was orchestrated by Ricardo Carvajal from Paris. And these are just the data from the opiates. And they were either used as sedatives or as analgesics. And you can see there's tremendous differences from one country to another. Greece, only 66%, and some countries like Malta, etc., Cyprus, almost 100% or 100%. And then they give either continuous only or bolus only, or a combination of continuous and boluses. So this is the practice in 18 countries in Europe. And at least this is one wherein these babies are intubated. Now, what are the drugs that are being used? And I think I'm presenting this so that our committee can look at this in terms of their choices. You can see that number one, there is morphine on the left side. Fentanyl, these are only the tracheal intubated or ventilated babies. And there's 2,000 of them over 6,000. As you know, the main number there is the 6,680. And more than 2,000 babies were intubated, and they were given morphine, and then fentanyl, sufentanil, and midazolam. Midazolam, however, was either an accompanying drug, is very seldom given by itself. And then you have their propofol, chloral hydrate, ketamine. Despite the fact that there is tremendous concern about ketamine, we know from the primate studies that they cause severe apoptosis when they're given to newborn animals. They're still using them. Who cares about those primates? Anyway, then they have paracetamol. And then they also have these kinds of treatment for non-invasive ventilation. In addition to that, they have those paracetamol. 16% of those babies were given them. Ibuprofen, local anesthetics, And the neuromuscular blockers, can you see that 23% in the tracheal intubated babies? Now, the NICH had published data to show that mortality increases in those babies that are given pancuronium. Do we really care? No, not really. They can still give them. And that they really, many of them don't believe in pain scale, you know, they will just give it anyhow. So that it's only about 65, 60% use them to adjust their dosing. Now, I was amazed by this withdrawal syndrome of only 1%. I'm sure that that was an understatement. To discuss with the committees what to establish priority, which drug should we study first? And if your decision is already made up, what and why did we choose that drug? So it's something that we have to think about. So when I look at this, because we see this in our nursery too. We have a baby right now who has been in the nursery for 6 months and is still on morphine. And the question is, how often does this occur? If you hit the literature, very seldom there is very little information. I found this paper by Tallulah Lewis, who is working with Dr. Estelle Gouda from Johns Hopkins, and they look at their emergency their ER, their records, look at these number of babies who were given morphine in their nursery, and then went on to develop this problem. And as you can see, they compared here 3 time periods: 2003, 2007, 2010 to 2011, and on the top left-hand side, you can see an increasing number of milligrams of morphine equivalents. They used morphine, fentanyl, hydromorphone, etc. They converted them to morphine equivalents over time. That was highly significant. But when you look at the days of where they were required weaning, you can also see them there, if you can see them, 53%, 71%, 82%, those required weaning. And when they have discharges of NAS, you could see that that was increases over time, 9%, 36%, and then 50%. The question that I had here then was, how long did these babies were treated? And again, that question was very difficult to answer. So I kept searching and found this wonderful paper from Rotterdam, from Dick Tibble's office. I think, were you part there of this study then, John? I can't remember now. And they described 30 babies who had congenital heart disease and had ECMO, all treated with, of course, pain medication. And then 15 of those babies survived. They were treated, except 5 of these babies went on to keep having this, and finally they discharged them. And they sent them home for treatment, and they were able to get rid of the treatment for withdrawal from 11, 42, 107, 107 to 180 days. So it is possible in their system to be able to treat these babies with what I call now a NICU morphine iatrogenic withdrawal. This is a disease that we are causing ourselves. So the other question I then ask is, well, we give morphine. How soon will these babies develop withdrawal? Tough question. There are some animal literature says that within 24 hours you can have develop tolerance and withdrawal. But there's one paper, I forgot to put it in there, by Sani Anand, who said that after 3 days, if you discontinue this medication, these babies start to show withdrawal manifestations. So 3 days is a magic number for them. There was a paper from Mass General Hospital during the earlier part of the ECMO period, where they clearly showed that fentanyl dose doubles within 4 to 5 days. What does it mean to me? That these babies now had developed tolerance. And that is your magic number there, about 4 to 5 days. Now, the question for us who prepare these protocols is, can we prevent this by alternating opiates with other analgesics like NSAIDs or propofol or whatever to avoid the addiction or tolerance? I'm not quite sure about whether this is possible, but certainly if it takes that long, can we just interrupt the cycle so that we may have less babies who have iatrogenic addiction? I don't know the answer to this. So we have all of these drugs, that wonderful drugs that we're using to keep our babies happy, at the same time setting them up for a long-term abnormalities later on. Remifentanil is increasing its use, certainly in the US, for rapid intubation. Ketamine, despite the fact, as I've said before, that it does increase apoptosis, still being used. And there's one that's coming out, dexmedetomidine. It's an alpha agonist that is supposed to have a sympatholytic effect, affects the potassium channel, and is a relatively good analgesic. So there are some other drugs that maybe we need to consider. The big problem is the outcome measures that we use. Again, we go back to this. How do we study these drugs? So there are 40 pain scores that I looked at, and there are 5 of them, or probably even 7, even the comfort scale and the cries. But these were the ones that were validated. Some of them were validated for gestational aids. I like the first 2 quite well, and that's what we used it, simply because I'm very familiar with them. The PIPS score was developed by Bonnie Stevens and Celeste Johnston when they were at McGill. And then Bonnie revised it to be more appropriate for gestational aids, and it's now called the revised PIP. She published that in 2014. And Pat Hamill also did a neonatal pain sedation scale, which you can use for sedation. It's a fascinating scale because it doesn't rely much on physiologic variables. It's mainly on behavior. The only things he's considering here is the oxygen saturation. And the national phasing coding system, etc., and the douleur aiguë du nouveau-né, or DAN. The problem with all of these is that they give you a severity score, but they're really not that very good in determining a severe pain to a minor pain. So that's where, again, our problem is. We don't know. Only the nurses tells us, this baby in acute pain, you need more morphine, or you need more Versed, or you need more of this. So it's the nurses who's telling us this. They're driving us. And they come with you with a chart. Here, you order it. And they won't stop until you do it. Now, are there other things we could do? Well, they have the near-infrared spectroscopy. I didn't find that too useful in the literature. Amplitude-integrated EEG, functional MRI, skin conductance. We did 2 studies on skin blood flow. You can show that in acute procedural pain, but it's not very consistent. And then the crying power spectrum, and then some biochemical hormonal measures as surrogate for pain. Cortisol will go up. There's some paper by Ruth Grunau suggesting that in some of these very small babies, they cannot mount a cortisol response, even if they are in severe pain. So how is that going to help us? Very little. So I think this is another challenge for our committee and for us to see whether or not we can develop a really good surrogate biomarker for pain so that we can do our proper analgesic therapy for these babies in pain. Now, going back to morphine, it is the preferred use in ventilated newborns, in part due to the respiratory depressant effect. The PK/PD of this drug has been very well studied. There's a number of acute adverse events. The metabolism of this drug is quite interesting. You know that codeine is a prodrug of morphine. This is the favorite drug of Dr. Johnny van den Anker here, the morphine one there. CYP2D6 metabolized codeine, and then it goes to morphine. He got a lot of RO1s for this work, that's why. And then morphine gets metabolized by UGT2B7, which has a lot of polymorphisms also into morphine 6-glucuronide, which is a very powerful agonist, or to morphine 3-glucuronide, which is an antagonist. It's quite interesting. So depending upon how this curve is shifted, either the baby has more morphine effect or a lesser effect. And why is that important? because the kinetics of morphine can be affected by some of these polymorphisms of these genes. Well, the PUP-PK, derived nonlinear morphine loading dose, etc., and maintenance dose had been worked out very well by the group, again from Rotterdam. They did quite a lot of work in here. In fact, I was telling Carol that he should be giving this lecture instead of me, because there's a lot of work that he had done in this field. And we know how to use it, assuming that we know what the target concentration is. And that is a big question. We can adjust the plasma concentration, but we have to know what we are targeting with. Then the other thing that I had shown is that polymorphism of the opiate receptor mu1, as well as the catecholamine methyltransferase gene, their SNPs can increase rescue. If there are SNPs there, that you could increase rescue morphine doses. So polymorphisms of these genes are important. And polymorphism of the UGT1B7, by the way, bilirubin is metabolized by UGT1B1, so this is a different UGT, alters morphine PK. And so that, in my view, pharmacodynamics should be a compulsory, now you can fight with me with that one, component of any drug developmental study. The bigger question is, I think, is a fascinating one, is the second one. What are the relative contributions of genomics, PK/PD, metabolism, disease state, and cultural and demographic factors in the final drug response? If you have the answer to that, I would really love to have it. And the other question is, how well can we study receptor sensitivity in these babies? You cannot just grind a baby's brain nor a baby's heart to look at the receptor binding capacity, but we have to find out some way, some technology at some point to understand this a little bit more. That is a challenge. So now I would like to go and look at some of these problems that we had with the morphine, because it's the most commonly used drugs. At the same time, it is one that where we have learned quite a great deal. So there are more than 20 clinical studies in the literature. About 7 of them are clinical trials, but only 2 of them really comes out and stands out. And that's what I'm reporting to you. Sani Anand's paper in Lancet in 2004, and the Dutch trial by Simon in 2005. And they are both double-blind randomized trial. It is a huge trial. I don't think that we can mount a similar study now. Almost 900 babies in the Neopain trial. The only difference, the major difference, I should say, between the two is that in the Anand trial, the Neopain trial, the dose was very much higher. Okay, 100 microgram, and then they keep giving 10, and then the nurse goes on and says, baby's a little bit more pain, and they give up to 20 or 30 micrograms per kilo per hour. As it turns out, this probably was very key in what we are going to say next. So the primary outcome from that Neopain trial is a component of neonatal death, severe IVH, or intraventricular hemorrhage, or periventricular leukomalacia. A huge number of babies. What did they find? Well, there was no difference in the primary outcome. So regardless, they were treated for about 2 weeks with morphine. Neonatal death was the same, and so was IVH or PVL. However, looking at shorter outcomes now, morphine decreased the pain scores. So there's no question that some of these babies, at least if you use PIP here and believe in it, that they were in much less pain. There were, however, many abnormalities, including feeding intolerance later on when they were able to be weaned off, and then increased hypotension. Many babies had increased hypotension, and they stayed in the ventilator much longer. What was more interesting was the open label morphine use. So even whether or not you are in placebo or in morphine, if you think that the baby was having problem, then they were given morphine. And in those babies who were given open label morphine, now the outcome is different. There is more babies who die now within the placebo group if they were given morphine. These are now no morphine versus morphine. There were more babies who died, and more severe IVH, and more PVL. Okay, so it's not good. So what happens to them? In the Dutch cohort, at 5 years of age, they have lower IQ in the morphine treated group, 94 versus 100. But by 8 to 9 years, these babies got better, and there was no more any difference between in the neurological outcome. The IQ was both 101 and 99, very close, not difference. The one thing that was very interesting was there were fewer problems with daily executive functioning in the morphine-treated group. It looks as though these babies were more organized and did better. So was what another non-controlled study from Royal Melbourne, I think, by a lady named Rachel Steinhorn, the daughter of Robin, together with Lex, who is at the back, followed a cohort of 233 babies. At term, they did MRI on these babies. Some of them were abnormal in the morphine-treated group compared to the non-morphine-treated babies. They had behavioral dysfunction even at 2 years. But by 7 years, all of those were gone. They were all comparable with the control group. With the non-morphine, I should say, receiving group. They again notice the same thing, that they have higher scores in basic educational skills. What is happening here? Is morphine really doing something and upregulating some of the repair mechanisms much later? I don't know. But when I compared this to the caffeine trial, it was quite fascinating because the opposite is happening with caffeine. You get neuroprotection early, and then the improvement is coming from the placebo group. Unfortunately, Dr. Anand was not able to get the funding to follow up these 898 babies. The NIH was not very generous in this regard. And it's too bad because we should have been able to learn quite a lot more on this, about these babies. Anyway, they were abnormal at 5 to 7 years, only about 14 and 5 babies that he was able to follow. So the reason why I'm showing this is that there are many genes that are upregulated very early on to protect the brain, and these probably continue on. These are animals treated with caffeine, and then we looked at, and then they were subjected to intermittent hypoxia to really destroy to destroy some of their organs, including the brain and the eyes. And neuropilin here, as you can see, was very highly upregulated by this drug. Neurophilins are very important because they provide axon guidance during development, and they also provide axon repulsive cues. In other words, if the axon is not going where it should go, they move them aside and direct them where they should go, and they repulse them if they are going somewhere else where they should not be going. I don't have time to go to here. One thing, though, is that midazolam is another problem drug for us because in the newborn, it is a depolarizing drug, or it's an excitatory drug. When it transitions into a hyperpolarizing or inhibitory drug substance, we don't know. And in animals, according to the data by Pfister, this occurs somewhere around 7 days in the newborn rat. And this is the most important inhibitory neurotransmitter in our brain and in the mammalian brain. So we need to probably look at this a little bit more. We know that in the young infant, this is 6 years old, up to is very high compared to adults. You can see that the more red and the more yellow it is. These are data from our work in Michigan. But we have no idea what happens before the 2-year-old until we measured it in 5 newborns, and GABA is there. We just don't know whether it's functioning as GABA inhibitor or as GABA is stimulant. So, but we know that GABA is in the mammalian brain. So this is another area where we need to do a lot of work. So I will move fast.
Very fast.
Very fast. There are controlled trials on midazolam. Basically, there's no effectiveness of midazolam here. And the one last thing that I would show is that in this follow-up study at 18 to 22 months in babies treated with midazolam in Vancouver, this was a work by Steve Miller, there was a negative correlation of these babies who had 2 MRIs and then look at the growth of the hippocampus. And the higher is the dose of midazolam, the lesser is the volume of the brain, of the hippocampus. And we know the hippocampus is very important for memory and for learning. The cognitive scores also was correlated, the Bailey scores, directly correlates to hippocampus volume. So the bigger the hippocampus, the higher is the Bailey score, but it's negatively related to midazolam dose. So I won't go into this. So what are the challenges? Well, we do need to work on having quantitative measures for pain. I'm not sure how we can do this one. The valid outcome measures, which morbidities or surrogates should we use for pain? I mean, many of these trials look at IV-AIDS, PVL, etc. I mean, are those really things that we should be looking at? Studies in the periviable newborn is that we treat many of these 25-weeker, but if you look at the data on PK/PD, very little available in there. The paracetamol data goes down only to about 26, 27 weeks. And yet we keep giving these babies this, assuming, again, that the data is similar. We know that those babies are different. These babies are very small. Appropriate duration of long-term follow-up. This is fascinating because we know that some of these drugs produce a neuroprotection like caffeine, or in this context, morphine, it does something very bad, apoptosis plus a few other stuff. And then it gets better again by about 8 to 9 years. We know that with what available data we've got. So at least there's some hope that whatever damage we've done, these babies will recuperate. The brain is plastic enough to do that. And then we aid maturation of drug metabolism, etc. The other challenge is linking imaging technologies, whatever we've got, and morphology, brain sizes, etc., to function and neurodevelopment evaluations. And then for the PK/PDs, physiologic-based PK/PD modeling should be available for us. Pharmacodynamics should be a very important component of some of the studies we do. And we have to keep on developing better technologies and feasible methods of studying receptor function in newborn babies. I will stop there, and thank you very much.